So we start with renal cell carcinoma, which is the tumor of the kidneys. It represents around 3% of all cancers, with the highest incidence occurring in Western countries. Risk factors include smoking, obesity, and hypertension, which is now very common in our region as well. So we see many patients from coming to our clinics as well with RCC. So preventive measures include increase physical activity, eliminate cigarette smoking, and obese patient reduce weight. So RCC has a classification of, it is classified into main uh, um, three main types, which are confirmed on the basis of cytogenetic and genetic analysis. Number one is clear cell carcinoma, which is the most common type. It is around 80 to 90%. Papillary type 1 and 2, which comprises of 6 to 15%, and chromophobe, which is 2 to 5%. Another cell type is known as renal oncocytoma, which is a benign tumor. So basically, we have three major types of renal cell carcinoma, and the most common one is renal cell carcinoma, which comprises 80 to 90%. This is a pictorial presentation of renal tumor. As you can see, it arises from the cortex to the medulla, and sometimes it presents as an exophytic lesion, and sometimes it presents as endophytic lesion, which are the small lesions. But majority of cases they present with an exophytic lesion, and sometimes it is not big early, so they present with large tumors like 10 centimeter to, I have seen in our clinics and operated upon up to 25%, 25 centimeter of a tumor, which is almost the double size of the kidney. So they usually present very late in our region. Symptoms include basically a classic triad of flank pain, which is visible hematuria and palpable abdominal mass. So it's not always present, but majority of cases they present with flank pain, hematuria, and palpable abdominal mass. Physical examination has a very limited role in RCC because it's not a superficial disease, but findings should prompt radiological examination if you find palpable abdominal mass, palpable cervical lymphadenopathy, and a non-reducing varicocele and bilateral lower extremity edema. Why this happens, why we have cervical lymphadenopathy? Because of the celiac trunk, the lymphatic vessels, they go up to the neck, and there are off and on we find lymph nodes, which are not which is not a good sign, because the disease is already spreaded everywhere, but you can find these things. The other thing is varicocele, bilateral, which becomes visible because of a large tumor or a space occupying lesion in the abdomen compressing the IVC. So once the IVC is compressed, the blood flow is reduced, the lower extremity becomes edematous, and visible varicocele is present on bilateral sides. Left varicocele is 25 is normally present in 25% of male individuals. But if you find a patient who presents with bilateral varicocele, which is non-reducing, or somebody presents with right-sided ipsilateral varicocele, so you should always think about examining the abdomen in this patient. You might find something which is compressing the IVC. So investigations include basic investigation like ultrasound, KUB, renal functions, urinalysis. So we make working diagnosis on the basis of initial investigations. And if you find a tumor in the ultrasound, we should always go for a CT urogram, which is also known as CT abdomen with contrast. Now in urology, we use the term urogram, which means the CT of the kidney, ureter, and bladder with contrast study. And MRI abdomen with contrast study. Why we use contrast in tumors? We never use contrast in stone patients. Like we see renal stones, ureteric stone, we only go for non-contrast CT. But when we are looking for a tumor, we always need to see on the cell activity of the tumor. So when we give contrast, it has a hot areas in the kidney or any tissue that we are looking for. So these hot areas represent tumors. So that's why we use contrast studies in these tumor cases. So, renal cell carcinoma management is basically surgical excision of the tumor. If the tumor is small in size, it is present at the polar areas that you can remove easily. So, it is always advisable to go for nephron sparing surgery. Nephron sparing surgery means partial nephrectomy, when you remove a pole or you remove the lower pole or upper pole or the mid region. Uh, but yes, this is only possible if you are away from the vasculature of the kidney, the major vasculature like renal vein and renal arteries and ureter. So if you can easily remove a salvage pole, it is always advisable to go for nephron sparing surgery. But if the tumor is large enough and or the tumor is compressing or present at the hilum, it is not easy to remove the tumor alone. So we always go for radical nephrectomy, which is a term used for almost every cancer that is tried to remove with all its roots and invasions. So radical nephrectomy is a procedure of choice in these patients. Cytoreductive nephrectomy is another term that we use in tumor nephrectomies, which means that the tumor is already metastatic and present almost everywhere. So, in these patients, when we are trying to debulk the tumor and we are trying to reduce the symptoms of the tumor itself, we are trying to reduce the blood loss from the tumor. So we go for cytoreductive nephrectomy that does not eliminate the disease completely, but it reduces the symptoms, it controls the blood loss, it controls the overall life, we can say, uh, the discomfort of the patient. So we have three major types of nephrectomies: nephron sparing surgery, radical nephrectomy, which is the complete excision of the tumor, complete removal of the kidney along with tumor, and cytoreductive nephrectomy, which is basically removal of the main site of the tumor, and there are other secondaries as well in the body that are managed later on according to need. Other management options, like in every other cancer, there is always an option of chemotherapy and radiotherapy. Unfortunately, in renal tumors, there is no role of radiotherapy or chemotherapy. There are different oral medications or IV medications which are known as cytokines that we use in tyrosine kinase inhibitors, and these medicines are used to minimize or reduce the cell growth of the tumor, but it does not completely eradicate the tumor itself. But it can halt the tumor activity, the cell activity. It can limit the tumor, but cannot remove it completely. So the other options include medical managements like cytokines and chemotherapy in some cases, which is not very helpful in renal cell carcinomas. So this was all about renal cell carcinoma. I'll move on to the bladder tumors, which is, I think, the most common disease of most common cancer of the kidney, ureter, and bladder. And it is, as you can see, it is the seventh most commonly diagnosed cancer in the male population worldwide, and it is the 11th most common cancer diagnosed in both male and females in worldwide. Male to female ratio is about 2:1. And again, etiology includes tobacco smoking, which is the most important risk factor, accounting for approximately 50% of the cancers that present to your clinics. You always find one thing very common, which was smoking. Either he is an active smoker, either he had a history of smoking and he quit it, but somehow it is related to the smoking. If you Like we say, like I used to say that when you see a renal cell carcinoma or when you see a bladder tumor, it is always that you find a smoker behind this disease. And those are the unfortunate ones, but there are majority of others as well. But you will always find a smoking history in bladder tumors. Environmental exposure to tobacco smoke, which is very important. This is passive smoking. You're smoking in a public area where you're smoking at home in front of your kids and family, everyone. I've seen many people do that at home. They smoke in their cars. They have their children on board and the family, and they're smoking with a closed environment. The air condition is on, so this is the environmental exposure to tobacco smoking that can lead to cancers in their family, the loved ones, those who are not actually smoking themselves, but they are getting the tumor from their father or a family member. So occupational exposure is the third thing, which is aromatic amines, polycystic aromatic hydrocarbons, and chlorinated hydrocarbons is the second most important risk factor. These aromatic amines and polycystic aromatic hydrocarbons, these are basically present in dye factories, the rubber dyes or color factories. They have these special chemicals for the exposure. So if a person is working in a color factory or a rubber factory or dyes factory, they can have an occupational exposure, and it can lead to bladder tumors. And the last thing is family history, which is not very common. We don't find genetic inheritance in this disease. Majority are acquired disease, and the most common risk factor is smoking. This is a pictorial presentation of the bladder tumor. This is the inside of the lumen of the bladder. This is the outer side of the bladder, which is fat covered. And in between, there are muscle layers. These are transitional cell epithelium. And there is muscles, there are smooth muscles around the detrusor muscles. So you can see multiple types of tumor. The CIS, which is present in the inner mucosa, which has no invasion into the mucosa. The other one is superficial disease, which is known as TA disease. It does not cross the lamina propria. The T1 disease is the one that goes beyond the lamina propria but does not invade the muscle layers. And after that, we find T2 disease, T2 disease is the one which is invaded into the bladder muscles, the muscular layer. This is the bad news. The rest of the TA and T1 and CIS, it is comparatively a good news, but when we see a T2 disease and onward, this is a bad news. So T2 disease is the one which is penetrated in the muscles. Some are superficially penetrated, some are deep penetrated into the muscles. And then again, then comes the T3 disease, which is present outside the bladder, but it is microscopic, which is mostly missed on the CT scans and everything, which is when we do the radical cystectomy, when remove the complete bladder along with this fat and layers, and then the histological finding reveals that it was a T3 disease. But when the T3 disease becomes macroscopic, this is known as T3B, and T3B disease can be visible on the CT scans. T4 disease is the one which goes beyond bladder tissues layers. It goes beyond the bladder layers, goes to the abdominal wall, can go to the rectum, can go to the prostatic urethra, it can go to the distant organs like liver and lungs, etc. So, what are the symptoms and signs? The key symptom of bladder tumor is hematuria, which is mostly painless and with the passage of clots. So evaluation includes history and examination like we do in every other patient. We should always examine a patient. We take detailed history and we do ultrasound and urine analysis. So ultrasound, in majority cases, ultrasound picks some tissue growth inside the bladder, the urinary bladder, and it has vascularity on doctor's ultrasound, so we can suggest that it's a tumor and it should be looked. Urinalysis means urine DR, the detailed reporting along with the culture and sensitivity. The cystoscopy and biopsy of the resected tumor is the second step. If we find a growth of in the bladder lumen, the second best step would be cystoscopy and resection of the bladder tumor. And the same time, we send it for the biopsy, and the biopsy will further clear the situation in that patient. After doing resection of the tumor and biopsy, if it turns out to be a tumor, we should always go for a staging workup like we do in every other tumor patient. Staging workup is the next best thing. You establish a diagnosis and you establish a staging of that tumor, that where it stands. It is either it is organ confined, or it is beyond, it is locally invasive, or it is present in distant metastasis. So we go for CT whole abdomen, CT whole chest, abdomen and pelvis with contrast. The staging workups. Contrast, again, I use the contrast because when we are looking for a tumor, we need contrast to see the hot and cold areas. So how we manage bladder tumor? It's a very complex disease, and the management is also very complex for your ease and comfort. And since you don't have to go through that very complex details of the tumor, inshallah, if somebody of you will be coming in urology, then he or she has to go through this before the final exams of urology. But to see it in a nutshell, I can say that it's a transurethral resection of bladder tumor. It is the first thing that we do, and then after removing the resection of the complete tumor in the urinary bladder, we go for a single instillation of a chemical antibiotic known as mitomycin C, which is also known for the effect of reducing the recurrence in that same patient. So it is a standard procedure that you resect the tumor and then you instill mitomycin C, which is known as SICA, single instillation of chemical agent. So we instill that mitomycin C. This is the first thing, and it is always it is in the guideline recommend that it should be given within the first 6 hours of the surgery. But if you find bleeding or mild bleeding from the tumor side, the resected area, you can hold it for a few more hours. But it's always advisable to give it within the first 24 hours of surgery. So the game begins once the histopathology is available. So it turns out to be a low-grade urothelial cancer, which is, I can say, like my teacher used to say, that if any cancer can be a good news, this is the low-grade urothelial cancer. You can always say that yes, it's a good news because the low-grade tumors are not very aggressive in growing and invading. So if somebody is lucky enough to have a urothelial cancer which is of low grade, the next best plan would be a close follow-up, a follow-up of cystoscopies, which we call it check cystoscopy, that we do after 6 months, and then we do it annually for next 3-4 years. If the patient remains growth-free for next 3-4 years, he is free to go and he doesn't have to worry about the disease recurrence. If unfortunately it turns out to be a high-grade urothelial cancer, then it's a bad news. So we give, if it's a high grade urothelial cancer and it is the muscles are not involved, it is a superficial disease, then it is always advisable to give BCG installation. Yes, BCG, which is commonly known as a vaccine of tuberculosis. It is the drug of choice in a patient who had high-grade urothelial cancer of non-muscle invasive nature. So we give an induction dose followed by a maintenance dose, and it is tailored according to the patient's health and need. It can be given to up to 2 to 3 years following the surgery, along with the closed check cystoscopies. Like in low-grade tumor, we used to follow in 6 months and then year, but in high-grade disease, we follow this disease 3 monthly with check cystoscopies for next 2 years, and then 6 monthly check cystoscopies for next 3 years. So it's a total of 5 years that is a close follow-up with drug installation in the bladder. It's not easy. It's not very comfortable for the patients, but yes, we have to follow it before it becomes invasive and things get out of control. Then comes the muscle invasive tumors. This is again a bad news. The muscle invasive tumor has no conservative managements or endoscopic surgeries. It calls for complete excision of bladder along with its pelvic lymph nodes, and the ureters are usually connected with the conduit outside the abdominal wall, which is known as ileal conduit. We take a small piece of ileum for this connection, and we make a bag which is connected outside of the body, and the urine comes out in the bag, which is emptied by the patient frequently. The other option is neo bladders, which are made with the help of ileum. But if a patient is young enough to have a good survival rate and a life expectancy of more than 10-15 years, it is always advisable to go for a neo bladder, otherwise make a conduit. So metastatic disease, if it is muscle invasive and it is metastatic, then there is no role of surgery. Then the option would be chemotherapy and symptomatic management. This is the role of surgery can be, again, the cytoreductive cystectomy to control bleeding, to control blood loss, and to minimize the symptoms, but we cannot remove the disease completely. So this was all about bladder tumors. There is massive detail in these topics, but I try to summarize it as much as I can. So now comes again a very common tumor of the urinary system known as prostate cancer, which is the second most commonly diagnosed cancer in men in worldwide. So etiology includes family history and genetics. So far, no specific preventive or dietary measures are recommended to reduce the risk of developing prostate cancer. But again, the research and studies say that it has a role with poor lifestyles like junk food eating, bad dietary habits, and heavy weight, obese patients. That's why this disease is more common in European countries. They have a high carb disease diets, and majority of the persons are overweight, and they pick the disease early. The signs are not specific, the symptoms are not specific. Majority of patients present with lower urinary tract symptoms. If it is associated with weight loss or bone pain, then we can go for a specific diagnosis. Otherwise, it is screened on a routine OPD. So people with a family history are screened with consent. This means why we take a consent, because there was a time a few decades ago in the European countries, this disease was overtreated. They started doing prostatic specific antigens, which is known as PSA, It is a blood test and it can give you a hint of tumor in the system. So they started screening the disease, and they found out that the disease was present in majority of person, and they started treating it. So the disease was over treated. Then again, they started making new guidelines, and they say that it's not always good to screen every patient, but if it has a family history, you should always check PSA with the consent of the consequences afterwards. Otherwise, don't screen it. So we don't screen in every patient. So detailed history examination, including DRE, which is very important, and other investigations include PSA, transrectal ultrasound, prostate, multiparametric MRI, prostatic biopsy, ultrasound or MRI guided, bone scans, histopathology. Acha. Once a tumor is identified and you have taken a biopsy and it shows a tumor. Sorry. It shows a tumor, which is majority of cases it is adenocarcinoma, which is almost 95% of the tumors are adenocarcinoma. So histopathology can give you a clue, but this biopsy does not come that easily. It's not easy to go for transrectal prostatic biopsy, which is a very painful procedure for the patient and very inconvenient as well. So majority of patients they are reluctant to go for this test. So after PSA and transrectal ultrasound, the latest guidelines recommend that you go for a MRI with contrast as a first line investigation. And if it shows a hot area in the prostatic organ, the prostatic gland, then you should go for a prostatic biopsy, which is a transrectal ultrasound guided or MRI guided. So histopathology turns out to be adenocarcinoma. It has three types on the basis of their cell types, like low grade, intermediate, and high risk. These classification does not include the biopsy only. It has the count of PSA along with histopathology and the age of the patient. So management, once the tumor is diagnosed and you have labeled it as an adenocarcinoma of the prostate, then again the question arises of uh, staging of the tumor. Either it is organ confined, either it is locally invasive, or it is distant metastasis. So these tests like MRI or MRI can give you the level of invasion in the pelvis and in the abdomen, and then bones can give you the level of invasion in the bones, because prostatic cancer, the adenocarcinoma, in majority of cases it penetrates into the bones first. So the bone scan is very vital to look for metastasis. So what are the management lines in CA prostate? If you diagnose a patient with the lowest risk disease of adenocarcinoma, which is scaled as less than 6 Gleason score, it is known as lowest risk disease. The minimal tissue or minimal portion of the organ involved, the Gleason score is less than 6, and the tissue and the tumor adenocarcinoma, which is known as lowest risk disease. And these lowest risk disease are treated with can be treated with active surveillance. But this active surveillance means a very promising nature of the patient and the clinician. If the patient is lives far across, it's not easy to come to the clinics, lives in the peripheries or vicinities. So it's not easy, always easy for the patient to come after every 6 months or 3 months. So in those patient, active surveillance is not the choice. You should always go for radical procedures. But if a patient lives in the same city or is a promising person who promises to come and on routine checkups, then it's good for active surveillance. Once you see a disease is progressing, you can always go for radical procedure in active surveillance. So, and the choice, the standard procedure of choice would be radical prostatectomy along with extended pelvic lymph node dissection. This is the complete excision of the tumor. This extended lymph node dissection is not usually recommended in low risk disease, but you can always go for intermediate and high risk disease. You should go for lymph node dissection. The other option would be radiotherapy. Uh, Another name for this radiotherapy is brachytherapy, which is the local radiation. It does not give harm to the surrounding tissue. We put radioactive beads in the prostatic tissue, which gives on radiation for a set period of time, and it damages the prostatic tissue only. But when we go for a general radiotherapy, it is given from the outside and it can damage the surrounding tissue for a bit. So these are the three basic options available for organ confined disease. Uh, but when there is metastasis seen, metastasis is present in the local tissue, you can always go for radical prostatectomy. But if the metastasis is present in the bones or soft tissues, you cannot perform the surgery only. You need the medical management. The other option would be, since we know that the prostate cancer increases with aging and it increases with high number of testosterone in the blood circulation. In elderly patients, this testosterone levels in the bloodstream are comparatively low, but in the prostatic tissue, these testosterone, dihydrotestosterone is always available, and it keeps on increasing the size of the prostate tissue. Either it is carcinogenic or it is normal, keeps on increasing in size. So if you want to halt the disease, um, the metastatic disease, the options would be medical castration or surgical castration, which means medical castration means blocking of the testicular activity to produce testosterone. This is anti-testosterone or testosterone antagonists or LHRH agonist, LHRH antagonist. They work on the pituitary system and they block the production of testosterone and they cause um, testicular failure. The other option would be surgical castration, which means complete removal of the testicular tissue from bilateral testicles. And this gives a surgical castration. In that case, you don't need to give in IV or intramuscular injections every monthly or 3 monthly, which are also cost effective. The other option would be chemotherapy, which is not the procedure of choice, which is a last resort in a patient who is metastatic and with a CA prostate. The chemotherapy is the last option to go for. So that was all about CA prostate. Now we'll discuss the last topic of our tumors of the urinary system, which is penile cancer. Penile cancer is very rare in our region. In industrialized countries, penile cancer is uncommon with an overall incidence of around 1 in 100,000 males in Europe and USA. Rarely seen in Pakistan because in my practice of urology since 2012, I have seen, I guess, 2 patients who were biopsied and turned out to be penile cancer. So it's not very common. The risk factors include phimosis in an uncircumcised male, chronic penile inflammation like melanoprostatitis related to phimosis, smoking, HPV infections, which are usually sexually transmitted diseases, Other is multiple sexual partners or the early age of first intercourse. These are usually the presenting risk factors of penile cancer, and it is unfortunate to say that now the habits and the cultures of different societies are going towards these risk factors, and unfortunately, we can have these cases in near future, Bhaskar. But it's always advisable to give awareness of these problems to the youngsters, to all the coming generations. We should always advise them to uh, to abstain these risk factors to avoid these kind of serious diseases. This is a chart I took. Basically, these all data that I'm sharing here is from the European Association of Urology guidelines of the tumors that we use in our practice as well. In our urology, we follow the EAU guidelines to go for any tumor management or non-tumor management. So this is the data that was present in the EAU guidelines. You can see the presence of this disease in different regions of the world. It does not have the names of the Asian countries. One of the biggest reason is we don't register our tumors or cases like other countries do. This is not something that we are free of the disease. The disease is present here. It is present rarely, but we don't register every case. So the registry system in Pakistan is not very strong. That's why our name is not on the list. But if we had a registry system, maybe we will be standing somewhere in these charts. So the diagnostic evaluation include most common presentations are non-healing ulcers on the penile skin or glands. So we always go for a physical examination, record morphologies, extent and invasion of the penile structures. Lymph nodes are palpable in the inguinal and pelvis. So it is advisable to go for CT abdomen and pelvis with contrast or PET scan, positron emission tomography scans. These are the best scans to pick metastasis. Biopsy of the penile lesion is the first thing to do. If you see a non-healing ulcer in the penile skin or glands or shaft, you should always biopsy the lesion, and then further management is advised. So the management, again, like every other tumor, the management depends on the site and size and invasion of the tumor. So if it is a superficial tumor, the organ sparing procedure is the procedure of choice, which is always, you can always go for topical chemotherapeutic application, which is 5-fluorouracil. 5-fluorouracil is a very potent chemotherapeutic agent used in multiple tumor managements. So you can always give it as a topical applicant on the tumor site. The other option would be laser ablation of the tumors with carbon dioxide and Nd:YAG lasers. Both of these are the laser types, and they are used to ablate the tumor tissue. But then, if the tumor is locally invasive, you can go for partial penectomy or glandsectomy with the reconstruction. You can go for total penectomy if the site of the tumor is on the proximal end and it is not feasible to do the organ sparing. We have to go for total penectomy along with formation of the perineal urethrotomy. So the total penectomy with inguinal and pelvic lymphadenectomies in a patient who have palpable disease in the pelvis or inguinal region. The other options would be chemotherapy like every other disease. So this was all about tumors of the urinary system. Basically, we had to cover urinary system, so I picked